and welcome back. And we're moving into our second conversation for today with representatives of the Ministry of Health. April 7th, tomorrow, is World Health Day, and this year the focus is on depression. We have with us Nurse Eleanor Bennett, who is the Nursing Administrator for the Mental Health Unit, and we have Dr. Marvin Manzanero, who is the Director of Health Services at the Ministry of Health. Good morning and welcome.
Good morning.
Thank you for being here.
I must say it's nice to have you guys in the studio. One of the things that we have been seeing in this country is the rise, especially that we mentioned that we'll be focusing on depression for World Health Day. What is depression?
Well, maybe if I just go back as to why it is picked up and World Health Day before we get to the depression. World Health Day is every April 7th, observed basically to highlight the foundation of when WHO started. It's been observed since 1950. And usually what happens is WHO, based on statistics, will pick a specific topic to highlight globally, which is where the topic of depression comes in, because it is a growing concern, as you rightly said, and because of the rise in the amount of cases, 300 million estimated globally. In some countries where it's perhaps much more diagnosed and treated than in Belize, or countries like Belize, it's estimated that only 50% of people get some kind of treatment for depression. And the rise also in a span of 10 years, from 2005 to 2015, was 18% increase in the total number of cases. And it is only expected to increase by 2020. It is estimated up to 20% of the global population will have some level of mental disorder. And that's the reason why depression was chosen as a topic to highlight. And we are trying to make sure that it is a topic of discussion beyond the specific day, which is tomorrow.
What is the consideration for the fact that perhaps the greater education on mental health perhaps has led to an increase in diagnosis of persons with mental health issues?
Yeah, well, of course, for us to pick up any disorder, you have to know what it is first. And so talking about it definitely creates more awareness, and people become more aware of their symptoms, and relatives become more aware of their loved one and suffering. So what awareness does is to help people define what the issue is. The first question was, what is depression? And we have to be really clear, it's a disease. Because some people like to say, oh, it's use these euphemisms to explain what it is. It's mental. It's a mental discomfort, or it's a state that I'm in. No, it's a disease. And when I say that, it's because there is a cause. It has its own symptoms. It has treatment, etc., etc. And doctor can tell you what classifies something as a disease. So definitely talking about it, the awareness contribute to the numbers and increase in the numbers.
Yeah, and to go back also to what Eleanor is saying, sadness is almost always made when people say, oh, you are depressed, and I think that's where we are also using the wrong terminology, because there's always the assumption that if you are sad, you are depressed, or that you have to be sad to be depressed, and they are not necessarily. Now, you see, depression can have, it goes to different stages. So it's not, you're not the smiley person outside, the person who has a smile on the face may not be seen as a depressed person, but there are perhaps subtle changes that start to happen in the patient before they actually have or are classified as a depressed person. And the person themselves might not be fully aware that they are depressed. It's subtle changes that happen. And there's many fluctuations in terms of what happens to you physiologically, from people having, for example, eating disorders. People lose appetite, some people eat a lot, weight loss. There's many subtle changes. People can put on weight, people can lose weight, people can sleep a lot, have insomnia. So there are different areas, and you can go from one end to the next end.
Yeah.
So that's why it's not that easy to make the diagnosis. Sometimes it is the persons who are closer to the individual that will start to not notice those kind of subtle changes. The person tends to start losing interest in the common things that they were normally interested in. They are not necessarily outgoing or excited about the usual things that would usually bring some level of attention. General tiredness, general weakness, sometimes being a little bit frustrated at work. So there's many subtle changes that start to happen over the course of time. But there's always flags that we, I think, tend to really not look at. We tend to take things for granted. We, I guess, don't like to talk about certain things. And that's why the topic is also let's talk, because it's you have to keep the conversation going. And I think one of the triggers also that has happened globally is that I always like to make the mention that we are not social beings that more. I think we are being caught up in this trend of technology where people are just very much more isolated, where the companion or their social entity tends to be the mobile device, the tablets. And I think the growing amount of teenagers and younger people who are caught up just posting things or talking to your tablet, or you don't know who you're talking to on the other end of the line. And that's why let's talk. It's a simple thing like that.
Yeah. So let's open the discussion about this disease. And I appreciate you saying that, because when we say condition, or I think a lot of times people just think it's a lot of sadness for one person and they'll get over it eventually. But you said disease for a specific reason. The brain is missing something. It's missing what is considered the happy hormone. Or not producing enough. Right? Am I trying to find a very simple way to explain it to people?
Yes, that's the most prevalent theory, is that it's a chemical, to simplify, it's a chemical imbalance. So our brain uses chemicals to communicate. And one of these chemicals helps our mood, helps us to concentrate, one in particular. And so what has been shown in people who are depressed is that the brain does not use this chemical efficiently. And so because of that, it affects the person's mood and the person's concentration. And it causes the person to feel extremely hopeless. And that is where suicidal thoughts come in. So a lot of times people think that when people think about suicide, it's a thought that they need to stop immediately, but not recognizing that some of these things are chemically influenced. And so why we know that this is the case is because many of the medications we use to treat depression, the mechanism of action is to correct or help the brain use these chemicals properly. And so we have to be very clear. It is a disease and it has a treatment. It has proven treatment. And so so that's how we want to present it, so that people understand its seriousness. It's a very serious condition.
It's not just something you can tell somebody, get over it, or you'll feel better soon.
Well, you don't tell people to get over cancer. You don't tell people to get over diabetes or
you tell them take your insulin.
Of course, you tell them take your insulin or change your habits or do something.
So is depression curable?
Yes, depression has a cure, and in psychiatry, when we talk about a cure, is that we mean that the symptoms don't recur. So we do have many cases where people have been successfully treated and never get symptoms again. But generally, it's a disease that tends to come and go if the person does not do certain things. For example, maintain their treatment or change lifestyle. So yes, but yes, the short answer, yes, it's curable.
You can be able to treat it with medication and also with therapy as well.
Right.
And there also has to be a family support that goes along with it, because it isn't just going to be that one person. Social support as well, and that's why we talk community support and trying to find structures and mechanisms to make sure we help out the depressed people. There's also the chronicity to it, because it's not really going to, once you start taking your medication, it's going to be 4 to 6 weeks before there is any real change that happens. So don't expect also people are going to get well from one day to the other. Depression can also have different masks, because we know we have an alcohol problem, for example. It could be that there is a reason why somebody's abusing alcohol. I think we have issues of anger management as well. Road rage, I think, has been prevalent over the last couple of years. There may be a reason why that is happening, so people are going to take elements out there. So it's not a silo situation, and I think as we go along, we're going to find more and more cases. So we do need to keep the topic of depression out there. It also accompanies other diseases. It can be a comorbidity situation where people have chronic diseases. You mentioned cancer, but there's the diabetic, the hypertensive patient, the HIV patient, and you may have had a patient that is borderline, if you will, and you have a chronic disease that comes on board, and that triggers that off and throws you off into depression. And one other element I think attached to it, whenever there is a death in family, there's going to be a period of the sadness where people learn to cope with that. That sometimes is equated and very commonly to depression. But you have a period where your body is going to be, you're mentally going to be able to adjust and come back to. But that can also be a triggering factor. But they are not the same thing. I mean, we have to be able to make that differentiation, and that's why we need to continue to talk about depression. I mean, for what it is, and I have to keep going back to saying. Also, the suicidal situation that you just mentioned. Because people will always come out and criticize. You have two elements attached to it. How can this person who has everything, everything, I mean, has a family, has a job, has a car, all those things that people look out for, how can that person have committed suicide? It's not, we can't be that judgmental. We don't know what that person has gone through mentally, and that you might be only looking at the face of something, but you don't know what's underlying the key issue behind that. So that's the reason why we also don't want to highlight issues of suicidal on the news, because there's many other elements attached to it. There is somebody behind that, and there may have been flags that we have missed, and I think we need to take a more proactive stance in that rather than being judgmental. See, that news doesn't take us anywhere. When somebody puts a headline that talks about, it's really not going to go anywhere. It doesn't benefit anybody.
Now, let me take the opportunity to look at vulnerable populations. Are there age groups or sexes that are more affected by depression?
Yes. According to our statistics and according to what the research shows, people in between the ages of like 20s and 30s, maybe 40s even, report for treatment most often, and I have to say it like that. However, all groups are vulnerable. Children can be depressed. So it's an issue for childhood as well as the older population, a population that we're very concerned about. There are many reasons why the older person might become depressed, some chemical, but some social as well. Society does not really embrace the older population very easily, and so we worry about them because this is a group that don't talk. They're older, they're set in their ways, and they wouldn't talk. In some countries, the highest incidence of suicide is among this population, over 65. So yes, it's an issue for older as well.
And sex?
Yes, women are affected slightly more than men. I think it's 2 or 3 to 1. So, and that's why people like to present it as a woman's disease, but it's really not. And that might be because of reporting, because of the way women seek help. Women are help seekers. Men aren't help seekers, they're doers and road ragers. Not that women aren't, but I'm saying men are they're
expected to man up.
Yes, they're activity prone, while we might want to talk. And
Now, while I can't analyze data like SIV or the people we're speaking to before, if we're to put the filter of suicide rates and successful suicide rates, we know men are more successful at suicide.
Sure.
Could this be a part of what we're seeing in the depression statistics, that perhaps men are struggling with, and this is an assumption I'm making here, men are struggling with depression but don't seek help as the women do, but they go to take action?
I would feel comfortable in saying that is so. Women attempt more often, and when women attempt, after that first attempt, it's very likely that they are going to be picked up by health services or are going to seek help. Men don't attempt so often. However, because they're manly, as Dr. put it, they, quote unquote, they resort to lethal and manly ways of attempting, but of course completing suicide. So, so while we have depression, the statistics are showing that women are affected more than men. For suicide, we have men more than women, and globally it's 4 males to 1 female.
Wow.
Yeah, but that may also be the way we culturally are structured, in that men is, I mean, they are not normally expected to be talking about elements of depression. So men are going to seek other avenues, and suicide might be a quicker door, if you will. But even
They're
so,
more successful,
there are still
in other
going to
words.
be flags that are there. But it's, again, they might not, the flags might be raised elsewhere.
No, one of the flags is suicidal thoughts,
Of course.
or speech,
Of
right?
course.
And this is, I think, let's look at parents, parents of teens, for example. You know, teenagers are an interesting group on their own, and very emotional based on their development. And so they say, oh, I hate this world, I want to kill myself. How does a parent know when to take that seriously?
Well, every verbalization of I want to kill myself should be taken seriously.
Okay.
And how you take, what that means is that it will not hurt to get some help or to consult.
Okay.
Of course, adolescents are sometimes very emotional, and we understand that. I hate you, I'm going to kill myself, and all of those things come as a part of the territory. And it's because of they're more impulsive than adults, they're less expressive than adults. But I always tell people, every verbalization like that has to be coming from somewhere.
Yeah.
Not everybody believe me, but but I personally believe that when people say things like that, it deserves some attention.
What about for expecting mothers? Because you're not able to take medication that you're recommended to take. You're expecting a baby. How difficult is this for them suffering from depression?
There are some medication that are safe for mothers to take during pregnancy. And when we get situations like that, we ensure that these mothers see a psychiatrist. But the benefit of medication has to be weighed against potential risks, and every medication has potential risks. So if it's a situation where the depression is severe and the woman is thinking about suicide, then more than likely she will have to be medicated. But there might be other situations where it is not that severe. We would try to send that person to a counselor so that she can have psychotherapy and see if it's going to help her condition. But medication during pregnancy, it's used cautiously and only if absolutely indicated.
We did mention family help. It's
Support
very important,
system,
family support. What do you do if in the home the individual is actually saying, you know what, I want to kill myself, and is attempting a few things, besides the family saying, you know what, I'm tired of this, you do whatever you want. We know that that is not help. How do you deal with this individual in the home while they're trying to act?
Okay, so if the person is verbalizing, I'm going to kill myself, and the person's at home, we always recommend, don't leave people alone, you know, always stay with that person. Get that person some help. That person needs to see a professional at this point. Yeah. And the support of the family is important. So a positive atmosphere is definitely needed here. It does not help to challenge the person and say, oh, if you want to kill yourself, see the belt here, or take the pills, I tired of hear you. Those comments are not helpful, but they're said very, very, very often. So that person needs a supportive environment where when they start to speak negative thoughts, the family is able to, or the support person is able to challenge that negativity. Because one thing people who are depressed and thinking about suicide like to say, nobody likes me, the whole world is against me. But if you really think about it, that's not true. So we have to teach families, and families have to understand that an atmosphere of positive is most important when you have somebody like this at home.
Now, you know, the topic is, of course, let's talk depression. And I think one of the things that we have to highlight is what depression looks like. And we were getting at it a bit earlier, which is, you know, people expect a very sad, mopey, you know, perhaps somebody's crying very easily. Is that the case? Is that what depression looks like?
I don't know if depression has a face. And I can draw the parallel to perhaps when we were trying to do this campaign with HIV, it doesn't have a face. Depression doesn't have a face. And as I said, usually the patient is not going to be the one who flags it. But they go about giving you different signs, symptoms. That's why I said all those subtle changes. I mean, people.
Which is why the people closer to you would see it, perhaps than a coworker or.
Eleanor mentioned something about not leaving somebody alone, particularly teenagers. You know. So I think we have gone into being a society where we are becoming very careless about each other as a community. Where teenagers are, you don't know who they are talking to, what they are doing, spending a lot of time on their own. So I think the dialogue is what is important. I think that is what usually starts to tease out the signs and symptoms, even for a healthcare professional who's seeing a patient. Maybe patient may actually be coming in for something else, for very unspecific signs and symptoms. So it really doesn't have a face. It's subtle changes that go along. It's a chronic thing. It's not going to be happening overnight. You're not going to be one day okay and the other day you're depressed. We may characterize it as such or use a term to describe it, but that's not really necessarily the case. I mean, there's many flags, I think, that are going to go up in that regard. But it doesn't have a face. Unfortunately, I can't tell you.
It's a person who does X, Y, Z. And I asked that question because I know that that's part of what we try to educate people about. It's paying attention to the details. So even if they seem happy but never want to leave their house, that could be an indicator. Now, the issue of stigma and discrimination is real, and my mind is triggered because when we reflect on the HIV situation, for example, a long time ago, nobody wanted to come forward and say, I am positive. We're better off now, and they still face stigma and discrimination. When it comes to mental health issues, there are some advocates who fearlessly stand up and say, I have this disease and I am living with it and trying to do my best to educate others. How important is it that it becomes the scenario where if I am living with depression, anxiety, and I'm coping with getting treated for my disease, that I'm able to say so?
Actually, it's one of the most effective ways of reducing stigma. And that is when someone who is living or have experience with the condition or with the disease is able to talk about it, talk about their struggles and talk about their successes. Because because people who are going through it can identify with those people who are talking about it because they have been there. I mean, it's something for me to come and tell you what the statistics says and what research says, and I can read off all the signs and symptoms to you. And that might work for some people, but when I get somebody who has been there, who was at the point of suicide, and have gotten treatment, and that person now comes and say to you, this is how it feels.
Yeah.
And I am an example that treatment works. And so, yes, so that's the most powerful way of helping people to understand what it is and to reduce the stigma that is attached.
From patients that you talk to, what are some of the challenges that they face because of the stigma and discrimination?
Simply just going for treatment. That's a big one. Nobody wants to be seen going to that particular office at a particular place, and nobody wants to be seen talking to this particular nurse. So they're saying one of the big issues we have is just getting people to come for treatment. They're ashamed, and they say, nurse, I don't want to come here because I don't want nobody to see me. Yeah. And that's what stigma does. Stigma actually comes from from us in society who don't have the disorder or the disease. We put that on people, and we mark them, and we present their disease as something of shame and a weakness, and so people internalize that, and that's why they don't want to come.
We've seen people who suffer from depression try to put themselves in an active position whereby they're playing a sport or jogging or running. How important is this, and is this helpful?
It's helpful, actually. It's very important, and there are things that help the medication to work. So lifestyle changes and involving yourself in sports. We always encourage that. It's people, when they're feeling depressed, have a tendency to want to withdraw. They want to be in their beds all day. They don't want to see anyone. So if you go to therapy, the therapist is going to encourage you to get involved as much as you can. Keep a regular routine, eat right, exercise, all of those things.
Actually, the Iceland experience is, for people who like to read, is a very interesting situation where Iceland started to find out that a good amount of teenagers were getting into this depressive kind of situation, very antisocial. Launched a national campaign that took years, and the changes they have done, going back to their running and getting involved in social and the arts events. Running also actually triggers off some of the chemicals that are antidepressants. So that's why people who have gotten into this running situation can have euphoria after runners. But now you also have to be mindful of people who do it excessively, because now you notice that you're having longer and longer distances because people are just overwhelmed, because it does create a sense of well-being, that they're running situations.
Now, we had up a photograph just now that I think will raise some questions, and I want to bring it to you directly, nurse, because some people think they can beat depression without getting medicated. And this is not always the case. I want to clarify, because we had it up just now, but some people will need medication.
Yes.
Well, that is very important that it's there, but I don't think the patient makes that determination.
Precisely,
That is done after you have gone through the process, because not everybody will want, but it's not that diagnosing myself as I am depressed and these are the things I need to do so that I don't need medication. That determination as to whether you need medication or not will only and can only be done by a professional. It's not that you take those points and say, okay, I'm going to write this down and then tomorrow I won't be depressed.
Or the psychiatrist tells you that you are, that you need medication, but you think that you can treat it on your own. Is this part of the challenge as well, that people don't want to take medication?
Well, it goes back to how serious people think this, or think that this is a condition or a state that they're in, and they don't appreciate that it's a disease that can have potentially serious consequences. So we do get that. We do get people coming to, I guess, all doctors and say, oh, that doctor don't know what he or she they talk about. I want to do my own thing. But we never recommend that. Depression, severe depression in particular, must never be underestimated.
Now, let's ask a question for family members or friends. If I perhaps identify, based on this conversation that I'm watching on TV, recognize that perhaps a family member or a good friend of mine may be depressed? I can't diagnose them, but I've seen changes that I think perhaps don't seem to be who they really are. How do I make that approach? Because I think so many people are scared to say, I think you need to go see somebody, or I think you may need to consider going back on your medication or seeking treatment. How does one make that approach?
Well, it's important that you know who the person is when they are themselves or not depressed.
Yeah.
And point that out to them.
Yeah.
Point out the changes that you observe, because you are there, you know them, you live with them. Tell them, listen, I noticed that at night you're not sleeping as much as you used to, and point out to them how this is affecting their daily lives, because depression, it does affect a person's life, in their social life, in their work life, and in all areas. It's not something that they can shake off here and then it's okay somewhere else. So families need to be able to point that out to them. I noticed this change in you, and it's doing this and this and this to you, and you need to see somebody. So that's the approach I would take, and that's the one I would recommend. I don't know if doctor would.
Let's talk. I mean, we kick it off tomorrow. I don't know if you want to talk about the forum. But I think from us headquarters level, it's also we are trying to ensure that this remains an item on the agenda.
Yes.
Ours using the forum tomorrow is an opportunity to get this let's talk notion about mental health issues, and we want to make sure that it's kept on the agenda going forward, that there's more resources available. I mean, if 1 in 5 of us are going to have a mental health problem, if we don't have it already in the next 3 years, then it is a serious concern. It is a leading cause of disability now.
Yes.
That is what it is, and so we need to be able to talk about it. So maybe talk about the forum.
Yeah, and you have this actually taking place on World Health Day tomorrow.
Yes.
It's going to be at the Princess Ramada Hotel. Is it open to the public?
It's open to the public. I say that cautiously, but yes, it's open to the public.
Yeah.
As many people as the Queen's Room can hold can come. It is also going to be the place where we get an official address from the Pahoehoe representative here, and then of course from the Ministry of Health.
Yeah.
And then what we are incorporating in this forum is to have people with real experiences talking.
Yeah.
And we thought that was important to the Let's Talk, because it really embodies the theme. We have people who are actually in this situation or had been in this situation that are going to talk about their experiences. And then, of course, we're going to be having experts that will be talking about what depression is, the overview of the statistics from the Ministry of Health. And then there will be a segment for people who are involved in activities that contribute to well-being or can help people manage their depression.
Like some stress reduction activities,
like
your yoga and meditation.
Meditation, relaxation.
It does help, right?
Yeah, definitely helps.
It helps even people without mental,
of course,
with diseases. So I think, the key thing really, and I hope we're able to achieve that today, is to just let people know it's okay to talk about this disease. If you can tell people you have a cancer diagnosis and be given the empathy that is expected, we need to bring ourselves to that same level with mental illness as well.
Definitely.
Yeah. Now, what happens in terms of actions from the Ministry of Health? Very clearly, we do want to say that there are clinics and nurses and doctors available, right?
Yes.
How does one seek help or talk to someone to see if they really are suffering from depression or any other mental illness?
They just come.
Any clinic, any public clinic?
Any public clinic. So in Belize City, we have at the Cleopatra White Health Center and at the Port Loyola Health Center.
Okay.
It's open and it's free to the public. And at each of the district hospitals, we have a mental health clinic there as well.
And so you just go in and say, I'd like to speak to
to a psychiatric nurse or a psychiatrist, or I like to speak to somebody about my mental health.
Okay.
Because we have made efforts to train the doctors in primary health care as well. So they are able to recognize and treat certain mental health disorders.
And again, for the forum tomorrow, it will be from what time to what time?
It's from 9 to about 12 at the Princess, the Queen's Room at the Princess.
And Dr. Manzanero, you were saying the effort is to keep this conversation going year round. How do we do that?
Well, one is making sure it remains on the agenda, trying to channel resources, cognizant of the fact that we have a problem, cognizant of the fact also that our healthcare workers may be depressed and undiagnosed. I mean, this is carry a heavy physical workload, a heavy emotional workload. From our stance, I think we are trying to move also away from just the punitive actions internal to the Ministry of Health, but trying to bring out all the positives in our healthcare. I mean, we get lashed every day for all the negative things that happen. And I know I have had discussions with Eleanor, because what I would want to do is, again, trying to take care of the healthcare workers, beginning with at headquarters, is run tests. I know we have had this discussion. Running tests to find out what kind of emotion, mental state our staff is in, and then be able to bridge out to them, and then that's where the discussion, I think, starts to happen.
Because they're in a high-stress profession.
So sometimes you actually have to take in all those patients that you are seeing, all their problems. You have to internalize that and go on to be a happy person somewhere else. So it's trying to engage. I think we are more than convinced. We will be there. We have said that tomorrow. And we will make sure that that topic remains on our agenda.
What about emergency care for mental health? What does one do? We don't have suicide hotlines in Belize, do we?
Not yet.
Okay.
We're getting there. It's in the works.
But what do we do if there's an emergency? If there's a time when somebody is really overwhelmed and it's 1 o'clock on a Sunday morning?
I think they need to go to a hospital. We will find a way of trying to get that person some level of assistance. We just had one this past Sunday. We will find a channel of making sure that is dealt with.
Okay, so the first responders are now trained to be able to identify and refer.
Flag it somewhere.
Okay. All right. Anything else we'd like to share about this topic?
Let's talk.
Let's talk depression. And the conversation continues tomorrow at the Princess Ramada Hotel, the Queen's Room. It is open to the public. Of course, if you get there and there are no seats, you can stand.
You can stand.
Yep.
But we do have some individuals who will be sharing their personal experience with different mental illnesses, some experts, and some other activities that they can do.
Right.
So, excellent. Thank you very much for being here today.
Thank you.
Thank
We
you
appreciate
very
it.
much. Okay.
That's right. Coming up in our third segment, we've got Kieran Davis along with Kirona, and I like the names, Kirona Davis. It is the Give Me This Mountain Life Conference 2017. That's when we come back.